Welcome to Journal Club Oncology. In this session, we shall discuss the recently reported 10-year outcomes of the PORTEC-3 trial, a landmark study evaluating the role of adjuvant chemoradiotherapy versus radiotherapy alone in women with high-risk endometrial carcinoma. Early stage low-grade endometrial cancer has a favorable prognosis, whereas patients with high-risk features including stage 1 deeply invasive grade 3 endometrial carcinoma with lymphovascular space invasion, stage 2 and above endometrial carcinomas, and aggressive histologies such as serous or clear cell carcinoma remain prone to recurrences and cancer-related mortality. Adjuvant pelvic radiotherapy has provided excellent local regional control, but distant metastasis remain the predominant mode of failure. The hypothesis underlying PORTEC-3 trial was that systemic chemotherapy, when combined with radiotherapy, would reduce distant relapse and improve the long-term survival. PORTEC-3 was a multi-center randomized open-label phase 3 trial enrolling 660 women between 2006 to 2013. Eligibility criteria included patients with stage 1 grade 3 with more than 50% myometrial invasion and or lymphocyte space invasion, and stage 2 to 3 endometrioid carcinoma or stage 1 to 3 serous or clear cell carcinoma. Exclusion criteria included carcinosarcomas, undifferentiated or dedifferentiated carcinomas, patients who have received prior therapy such as prior pelvic radiotherapy or prior chemotherapy, patients with extensive comorbidities contraindicating the pelvic radiotherapy or chemotherapy, patients with active second malignancies and residual macroscopic disease after surgery, and patients with extra-abdominal spread or distant metastasis and nodal involvement beyond the para-aortic nodes, and incomplete or inadequate surgical staging were the exclusion criteria of the study. The study had two arms. One arm was standard radiotherapy alone, patient receiving EBRT of 48.6 Gray with or without vaginal brachytherapy, and chemoradiotherapy arm consisted similar RT protocol with 2 cycles of cisplatin given during the RT, followed by 4 cycles of carboplatin and paclitaxel. Endpoints studied were overall survival and failure-free survival as a core primary outcomes. Surgical management included patients underwent total abdominal hysterectomy or laparoscopic hysterectomy with bilateral salpingo-oophorectomy and systematic lymphadenectomy or lymph nodal sampling left to center discretion. Para-aortic sampling recommended if macroscopic pelvic or para-aortic nodes were involved. In serous histologies like serous or clear cell carcinomas, there was a strong recommendation for full surgical staging, including omentectomy, peritoneal biopsy, and lymph nodal sampling. Central pathology review by reference gynecopathologist was mandatory before randomization, ensuring the accurate eligibility. Looking at the radiotherapy protocol, patient received standard 48.6 Gray RT in 1.8 Gray fractions 5 days a week with a clinical target volume including proximal vagina, parametrial tissues, internal, external, and common iliac nodes up to L5 to S1, and RT field extended to aortic bifurcation if iliac nodes were involved. Lower para-aortic region was irradiated if common iliac nodes were involved, and higher para-aortic region was irradiated more than 2 cm above the highest involved node if para-aortic nodes were involved. Brachytherapy boost was given if cervical involvement in form of glandular stromal involvement was present, with a dose equivalent to 14 Gray in 2 Gray fractions. Chemotherapy regimen in PORTEC-3 trial was during concurrent phase, cisplatin of 50 mg per meter square IV given in week 1 and week 4 of EBRT, and during adjuvant phase, 4 cycles of carboplatin paclitaxel with a 21 days interval was given. Study was designed with 80% power to detect a 10% improvement in 5-year overall survival, which corresponds to a target hazard ratio of around 0.67. Event requirement to achieve adequate power was 198 deaths with a sample size of planned sample size of minimum of 655 patients, which was increased to 670 patients to account for ineligibility or dropouts and ensure 655 available cases. Very briefly discussing the 5-year results, failure-free survival was significantly better with the chemoradiotherapy arm, whereas overall survival, there was no significant difference between the two arms at 5 years. Looking at the 10-year outcomes, at median follow-up of approximately 10 years, 10-year overall survival was around 74% with CT-RT arm versus 67% with RT alone, with hazard ratio of around 0.73. This corresponds to a 7% absolute survival advantage at 10 years. And 10-year recurrence-free survival was 72% with the CT-RT arm compared to 67% with RT arm with hazard ratio of around 0.74. This reflects around 5% absolute improvement in disease control. Even at 10 years, pelvic relapses were very low in both arms, showing that pelvic irradiation with or without chemotherapy provides excellent local control. The big difference were in distant metastasis. The chemoradiation arm had a fewer distant recurrences. In earlier analysis, it was around 20% in CT-RT arm compared to 30% at 5 years in favor of CT-RT, and this trend continued at 10 years. This reduction in distant spread is likely why we now see an overall survival advantage. There was no significant difference seen in recurrence patterns between the both arms. However, more distant recurrences in RT alone arm was seen compared to CT-RT arm. Looking at the timing of recurrences, majority occurred in first 2.5 years. 67% of recurrences was seen in CT-RT arm and 81% of recurrences were seen in RT arm in first 2.5 years, whereas late recurrences after 5 years, 15% of recurrences were seen in CT-RT arm compared to 7% in RT alone group. Looking at the characteristics of late recurrences, majority of late recurrences were low-grade tumors, more often in non-specific molecular profile subgroup, belong to ER positive subtype. Looking at the subgroup analysis, in stage 3 disease, overall survival was improved to 69% with CT-RT arm compared to 56% with RT alone, with absolute survival advantage of around 13%. Similarly, in serous histology, 10-year overall survival was on 57% versus 41% favoring the CT-RT. These data strongly support combined modality for aggressive histologies. The addition of TCGA-based molecular classification has transformed the interpretation of the study. In P53 abnormal tumors, 10-year overall survival was around 52% in CT-RT arm compared to 36% in RT alone group. Similarly, recurrence-free survival was significantly improved in CT-RT arm, showing clear evidence of substantial benefit from chemotherapy. In pole mutated tumors, 10-year overall survival was around 98% irrespective of the treatment. So no incremental benefit was seen with the chemotherapy. So de-escalation is warranted in that group. In MMR deficient tumors, overall survival and recurrence-free survival was comparable between the two arms. So there was little evidence of benefit from chemotherapy. So these tumors may be a better candidates for immunotherapy in the future. In non-specific molecular profile groups, outcomes were intermediate and CTRT showed a trend toward benefit but was not statistically significant. And ER status further stratifies the prognosis. ER positive tumors fares well, whereas ER negative group has a poor outcomes and may require treatment escalation. Looking at the strength of the study, it was a randomized multi-center phase 3 design across 6 countries. Study has clearly defined high-risk population and study used standardized intervention reflecting routine practice, and patients were treated with a pelvic EBRT of around 48.6 gray and a widely used chemotherapy backbone of cisplatin sensitization during RT and adjuvant carboplatin and paclitaxel, and brachytherapy indications were specified for cervical involvement. It was the intention to treat analysis with high follow-up completeness, and central pathology review was mandatory before randomizing, which reduces the misclassification of histology, grade and treatment variability. Other positive point is the study has demonstrated clinically meaningful long-term benefits, and molecular correlative analysis was done in the study with the post-hoc TCGA classification showing who benefits and who is likely not, suggesting the precision adjuvant therapy. This study had practice-relevant comparator arm comparing RT versus CT-RT. RT alone arm delivers excellent local control. The increment value of systemic therapy is attributable to distant metastasis reduction, matching the clinical need. Looking at the limitations of the study is slightly underpowered for overall survival at final analysis. As observed OS events were fewer than planned, it was 189, whereas 198 was expected. There was a heterogeneity of iris category with pooling of stage 1 grade 3 or LVSA with stage 3 and clear cell and serous varieties, which creates a risk dilution. Lymphadenectomy was optional, nodal assessment was not mandated, which poses potential stage migration and prognostic heterogeneity across the sites, which could influence the failure patterns. Molecular analysis was done post-hoc with incomplete tissue, and molecular classification was available only for 60% of the cases. Accrual for the study was done between 2006 to 2013. which predates today's routine molecular guided adjuvant therapy. This is one of the limitations. And key takeaways of this study is CTRT provides durable overall survival benefit and recurrence-free survival benefit at 10 years with absolute OS gain of around 7%. Stage 3 and P53 abnormal tumors derive the greatest benefit. These patients should receive combined modality if they are fit. All mutant and MMR deficient cancers show no meaningful benefit from chemotherapy, so de-escalation or alternative systemic therapy should be considered in that group. Molecular classification is now essential for guiding adjuvant decisions. Guidelines are evolving toward precision adjuvant therapy, and PORTEC-3 provides the evidence base for this transition. PORTEC-3 trial with its 10-year outcomes establishes that adjuvant chemoradiotherapy improves long-term survival in high-risk endometrial carcinoma with greatest absolute benefit in P53 abnormal and advanced stage diseases. Simultaneously, it demonstrates that treatment intensity can and should be tailored by molecular subtype, sparing unnecessary toxicity in biologically favorable groups. Thank you for joining this discussion of PORTEC-3 long-term outcomes. Thank you.